and it was one of those people that had apprehension before I worked in a centre that saw sort of drug users and sex workers and street kids, and I have to say I feel very privileged that I was able to and continue to work in that field. But you're right, it's a job ahead of us, I think. So yeah, I am the director at the Medically Supervised Injecting Centre in Sydney. Yes, it is a long way away. It's been 36 out of 48 hours travelling to get here, so I'm sorry that there's not more people, I think, that are here. I think some people are caught up in the famous ash plume of the volcano. So I'm just going to try and give a bit of a whistle-stop tour of what's going on around the world, and obviously, this is not, my work, but drawing on information that's available from a number of different sort of organisations and individuals about what's going on in Europe and outside Europe as it relates to drug consumption rooms. We tend to say supervised injecting centres in Australia, but I'll say drug consumption rooms or DCRs because that's all what's referred to internationally. So in terms of how many there are and where they are, supervised injecting centres or drug consumption facilities, as most people know, are places where drug users can go with pre-obtained, pre-purchased illicit substances and inject in a safe or safer supervised environment. They tend to be set up in places where there's high concentration of public injecting and supervise those injections that would otherwise have occurred often alone, often in public, in less safe, unsanitary surroundings. The first one was set up in 1986 in Vernon, not the first one, but sort of the first official one, is always said to have started about 24 years ago. And they've obviously expanded both in number and geography since then, spreading out across Europe, and now there's a total, I think, about 90 in Europe. And then, of course, you've got the rest of the world too. So I think Europe versus rest of the world, Europe wins. And most of those are in the Netherlands and Germany, although I understand there's more and more coming in Spain planned for the future. So certainly in terms of the context, when you compare Europe, say, to the rest of the world, there's lots of them, and they're in lots of cities. I think 59 cities at last count have got a drug consumption room across Europe. Traditionally, they were set up as local solutions to local problems, and I think that's worked well and served them well. It was often very much a public amenity aim that they were set up to address, so the chains of commerce or equivalents in certain settings were the people that were pushing for drug consumption rooms, whereas perhaps more in Canada and Australia, it's been more of a public health imperative that has seen us set up. Though obviously there's public health amenity aims and objectives that we have achieved in both sides. In Europe, as well as elsewhere, they're integrated with social welfare as well as other drug user services. But I think in the European context, the evaluation and the research was much more something that came after the setup, and that's very different, obviously, to the two in Sydney and in Vancouver. And I think there's perhaps a sense of safety in numbers. When there's 90 in 60-odd cities, I think you do have a sense of, there's safety in numbers with us. Whereas, for example, I know in Sydney, I'll be really interested to see Liz talking about Vancouver. When you're an N=1 site in your reach, not only for the city but for the state and for the country, I think there is a sense that, for the critics of harm reduction, if they can topple you because you're what they aim at as the pinnacle and pointy end of harm, then that's where their sort of strident criticism and opposition is often focused. So elsewhere, yes, there are only two, Liz and we're it. The centre in Sydney in Australia was set up in 2001 and was obviously the first outside Europe and therefore the first in the English-speaking world. A couple of years later, followed by Insight. They were both set up as trials and both set up really to produce evidence. As I'll go on to later, I think in some ways, because of the structure of the evaluation team in Canada, there's been some lessons learnt and things that I think Insight has done better, perhaps, than we've done in Australia in terms of providing evidence. And they're both were set up with specific enabling legislation. So that means that there's exemptions that allow the centres to continue to operate. I think both also claim the dubious privilege of having prime ministers of their respective countries explicitly opposed to the services and yet to still be operating. In terms of the evidence about drug consumption rooms, these come from a number of studies in Australia, in Vancouver, and from the rest of the world. Look, it's a busy slide, and if you take one thing from it is that there is evidence of the effectiveness of drug consumption rooms. They reach their target audience, so they reach the drug users use them, and importantly, the drug users that do come tend to be the ones that need it most. So, for example, in Australia, there was some work done looking at specifically at King's Cross and saying probably about 80% of the local users at any one time made contact with the centre, and those 80% are the most marginalised, the most likely to be homeless, the most likely to have mental illnesses, the most likely not to be accessing other services, and clearly they're the ones that we want to make contact with. They reduce the morbidity and mortality associated with overdose. Now this has been a hard one in terms of, certainly in Sydney we always get the question, yes, but how many lives have you saved? How many actual people have you saved? And it's pretty hard, number to come up with. There's all sorts of different methodology out there, and so the estimates vary wildly. The reality is when you think that there's been well over 10 million injections at drug consumption rooms around the world and not a single death, that alone I think would suggest to you that they do save lives. And the reality is when you're giving oxygen and Narcan to people that have stopped breathing, even if they weren't going to die, they certainly potentially were going to lose some brain cells. And so there's a very important role, I think, that drug consumption rooms play, not just in reducing mortality, but also in reducing significant morbidity. And obviously there's other health issues, and this is where I think sometimes our evidence is hard to get together. But do we refer people into other services? Yes. Do they make use of those other services? Yes. Do people access specific treatment services as well as other health-related services as a result? Yes. We're an extension of an NSP, and given the evidence for NSPs reducing specifically HIV, again, you would argue that there's evidence in terms of drug consumption rooms. They certainly reduce public injection and the discarding of public injecting equipment, and that's one of the key reasons, I think, in terms of improved public amenity, that they can and do often have the support of the local community. People would prefer not to see people injected in public places, in laneways, in their backyard, in a street corner, and would prefer them to be in a supervised sanitary place. Reduced reported syringe sharing has definitively been seen, associated with an increased uptake of drug treatment services, and that was a study specifically that came out of Insight and showing 30% increase in the uptake of treatment services. I think they very definitely have a role for peer education, and I think that's probably something in some ways that's been underutilised in terms of options for education and expanding and getting messages out there. They can certainly act as an early warning system, and I know, for example, in Sydney there's been a number of things that we've seen, both when there was a brief period of time when we've seen brown heroin coming in and the need for citric acid, which is obviously it's something that you see in the UK. It's not something that we've really ever seen in Australia. There was a brief period of time where that was an issue, and we were able to sort of see that much earlier and react to that than would otherwise have been known. Certainly also in terms of changing drug trends, we know around the world that we're seeing more and more Oxycontin and MS-Contin being injected, and again we can see and specifically quantify that so that we know, for example, again in Sydney since 2005 we've seen an increasing amount of supervised injections for those other opioid drugs, and in fact to the point that they significantly outweigh the number of heroin injections now. They are generally accepted by local communities. Certainly in Sydney we've had the majority support not only of the local residents but also of local businesses. That support has actually increased over time, and in fact is highest amongst the people that have been living in the local area for a long time, and that's because they know what the place was like before the centre was there. They can be cost saving. Again, there's a number of studies both that have come out of Insight, some that have come out of Sydney as well, and one that was done by some economists who said, quote unquote, you only need to save 0.4 or 0.5 of a life a year to be cost neutral in terms of sheer monetary numbers, and primarily that comes from reduced mortality associated with overdose. But again, there's a lot of other areas where they can be cost-saving. And just to mention the Vancouver Injection Drug Users Study, which was obviously a cohort that was set up before MSIC opened, I think has been invaluable in being able to produce some really high-quality evidence of an intervention, which we've not been able to do in Sydney. We have, more recently, our second of 3 independent evaluation teams set up a cohort, but for various reasons it's been difficult. And I think the pre-existing study of MSIC was exceptionally lucky and has been really made use of in Vancouver. Important negatives. So there isn't any evidence that they promote drug use. That's important. That's one of the key criticisms that we often have levelled at us, that if that somehow we're saying drug use is okay, and there really isn't any evidence either at an individual or at a community level that drug consumption rooms lead to an increase in drug use. Nor is there any evidence that they delay entry into treatment. So there's that sense that not only are you encouraging drug use, but people that would have been getting off drugs somehow aren't because it's easier for them to use drugs. Just the opposite. And also no evidence that they increase drug-related crime. We certainly in Sydney had a lot of criticism levelled at us that we were going to create a honeypot effect, and that drug users were going to come from around the state, around the country, and that there was going to be resultant problems from that. And there's been no evidence, 3 studies that have been done specifically looking at that have found no evidence of that. So they're important negatives, I think. Internationally, the UN AIDS versus UN drug agencies, I think, there's been a number of things mentioned in the other sessions that I won't spend a lot of time on, but historically there has been some tension between UN agencies that are looking at reducing HIV/AIDS versus the drug control arms. I think that's very much lessening, and there's some very good, obviously the technical guide again that we've heard about, and the consensus from UNAIDS, UNODC and WHO, and the 9 key areas targeting HIV for injecting drug users and NSPs, including one of those, is a really positive step. The role of the International Narcotics Control Board, the INCD, has been an interesting one. We got a visit from the INCD last year when I was there, which was interesting. So obviously this is a body that is expressly and explicitly opposed to drug consumption rooms. This is a 13-member body, sort of quasi-judicial, but charged with monitoring compliance with international drug control treaties. And I guess, you could spend a whole 20 minutes just talking about that, but I think importantly there is, the legal affairs section within UN has specifically done some legal advice looking at do drug consumption rooms violate the treaties, and very much the sense is, know that some of these treaties were set up for harm reduction is even understood, and that I think there is an agreed consensus that we are hopefully moving away from something that focuses exclusively on drug control and an increased emphasis on public health. In terms of Europe, I think again we've heard from some of the other speakers that there is an increasing emphasis and consensus, I think, in national policies, not without exception, but I think by and large there's an agreement that there's a convergence towards harm reduction being accepted. I don't think then it's a coincidence that we do see more drug consumption rooms in Europe, and I think that's important in that they are increasingly speaking as a single voice with consensus at an international level, and that's going to be important for us in terms of advocacy in the future, I think. A bit of a plug, I got a link to this, but this is available in the bags that you get, and I think this is an incredible resource put together by the EMC DDA, and tracks a lot of relevant stuff about harm reduction, and there's a specific paper in there about drug consumption rooms. So in terms of drug policy elsewhere, I think we've got some very positive stuff coming out of Europe. What about everywhere else? Well, look, I think there's probably more strident opposition seen where single services exists. You can argue which comes first, the chicken or the egg. I think I'll be interested again to see what Liz says in terms of what's happening in Vancouver. But I think in Australia, for example, Australia is seen as a flagship of harm reduction, and our rates of HIV amongst injecting drug users are the lowest in the world. So even in a country where harm reduction is accepted, drug consumption rooms are not necessarily safe at all. And I think so. For example, query risk of closure. So Barry O'Farrell is the current leader of the opposition. So the drug consumption room in Sydney is a state-based initiative. We have an election in March of next year. The current government, which is generally sort of considered to be rather on the nose, even though our new Premier is very popular, the leader of the opposition, quote unquote, says, while accepting the centre has helped reduce deaths associated with heroin addiction, I remain concerned that it's failed to meet its second goal of providing a pathway to rehabilitation for people who want to end their addiction. So this is someone that said, yeah, you save lives, but that's not enough. You have to get people to stop taking drugs. So we are now on, in Sydney, our third independent evaluation, and we do say that we think we can lay claim to being the longest trial, given it's nearly 10 years since we've been running. But the third independent evaluation is due to come down in July. We're very much hoping that between then and the election that we're able to see our service integrated into other public health services and the trial status overturned. We're not saying that we want to be, come enshrined and permanent forever, because, in public health, what is permanent? But we are saying that we want to take the political aspect to our service out. So at the moment, the legislation is heard every 4 years in Parliament. That's obviously tied to an election cycle every 4 years. So inevitably, we become a political football. So it will be interesting. The next sort of, year for us will be very interesting, I think. So in terms of lessons learned for establishing a drug consumption room, political leadership and a political champion, I think, are imperative. And I don't think these days that you could set up a drug consumption room somewhere where I think you didn't have that. I think having a sound legal basis that cannot then be challenged again. When you look at what's happened with Insight and the Supreme Court and appeals and whatever, I think ensuring that you have a sound legal basis before the service is set up is imperative. I think where possible, if you can have the support of police and law enforcement, it makes your job an awful lot easier, because these are the people, generally speaking, that the public expect to be against you. And if you've got people, for example, in Sydney, we've got two responsible authorities, one of which is the Commissioner of Police. So where you've got the police as traditionally the people very much supporting, the control side of things and the drug supply side of things. When you've got the police turning around saying, yeah, I think a supervised injecting centre or a drug consumption room is a great idea, I think that's incredibly positive. Community leaders and others in the local community need to be supportive, and it's obviously especially including the drug users themselves. The service needs to be designed to suit the local needs, and I think that's, you can't have a one-size-fits-all, not only because of the specific problems that you need to address, but also because of the politics of any local area. Obviously, it needs to be integrated with other relevant services, and again, that's partly designed to suit local needs. So, for example, in Sydney, there were a lot of other specific drug user services. We didn't need to replicate those, but we needed to be able to integrate with them. In other places where you haven't had a lot of other drug user services available, then that can, become part of the actual consumption room itself. Realistic and measurable goals. The measurable one is hard, and I think we do need to be get better at producing better evidence about our actual outcomes. Obviously, we're only one aspect of a response to a drug problem. We know that, but sometimes communicating that, I think, is imperative. Being media savvy. Consultation and consensus wherever you can reach it beforehand rather than afterwards is obviously useful. Know your friends and enemies, you're going to have both. Funding source as well. It's interesting, in Sydney we often talk about the fact that our funding does not come from health, but it comes from the confiscated proceeds of crime, and we found that in our context to be something that helps people overcome potential opposition, because it's not like we're taking money away from treatment services. When the reality is, as a harm reduction service, should we be concerned if our money was coming out of health? Well, no. But in our local context, it's been used for us to say, it's not an either-or situation. We're not actually taking any money out of the health budget, and so in that sense, that's been helpful. I think the other thing in terms of Sydney that's probably been helpful is the role of the church. So we're actually run by Uniting Care, which is the sort of social responsibility arm of the Uniting Care Church, or the Uniting Church. And I think certainly initially, not so much now, but initially and early on, that was very helpful for people who had a real ideological position opposed to drug consumption rooms, to say and see that a church was supporting it, I think helped change a lot of people's minds. So last slide, challenges ahead. Look, I do think we have some. Changing patterns of drug use and different harms, and how do we respond. Sustainability and even, God forbid, increasing numbers, especially where single services exist, is an issue. Again, looking at Australia, again, where single services exist, we hope that we're still there after the next election. Can we improve available evidence? I do think we need to get better at that. And I think one of the challenges, because we are spread around the world, trying to get some multi-site, research is going to be important. Again, also, even where you get some international evidence, then you've still got people turning around and saying, oh yes, but that's Vancouver. That's not necessarily the same as Sydney. But I think if we can improve our international collaboration, that would be of help. And so on that note, in terms of acknowledgements, the INDCR is the International Network of Drug Consumption Rooms, and this was a group set up in Bilbao before my time, sort of to exchange knowledge between drug consumption rooms, improve the possibility of multi-site research, to harmonise the drug collection from drug consumption rooms, and to provide support for those existing rooms and those likely to be set up. So thank you to them. I think there's going to be a few of us that might get around and have a natter afterwards about drug consumption rooms, which people are interested can join in. And again, for anyone that wants just some general information, I've got a fact sheet about the Sydney Supervised Injecting Centre, and that's my email there if people want to email me any questions that you don't think of or don't get a chance